Welcome, everyone. We're so glad that you could join us this morning. For some of you, it's morning, some of you, it's afternoon, and some of you, it's evening. My name is Mindy Reiser. I am a sociologist, and I am delighted to introduce you to our panel and give you a bit of a description of what we're going to be in store for in the next hour. We are going to be talking about documenting sexual violence, furthering reporting and prosecution. And as you well know, sexual violence does not stop at national borders and is a serious transnational concern. Physicians for Human Rights is a non-governmental organization employing science, medicine, forensics, and public health to protect and defend human rights. And it has been devoting considerable attention to the issue of sexual violence. To this end, PHR, together with end users in healthcare, law enforcement, and legal practice in Kenya and the Democratic Republic of the Congo, has developed MediCapt. Much more about that this morning. And that is a mobile application to improve the collection, documentation, and storage of forensic medical evidence of sexual violence. The application converts a standardized medical legal form used for the collection of forensic evidence to a digitalized format and combines with a mobile camera to enable forensic photography. To give you a much more comprehensive sense of what this is and how this came about, I want to introduce Karen Namer, who oversees all activities within PHR's program division. Her oversight includes research, investigations, asylum, capacity development, and advocacy-related projects. She also supervises initiatives ranging from PHR's U.S. asylum network to international programs focusing on documenting and responding to sexual violence in conflict zones and mass killings. Karen was the founding director of PHR's program on sexual violence in conflict zones and served in that role for 10 years. And now let me turn over to Karen.
Thank you, Mindy. We're so grateful to share this update as a 2019 recipient of the AAAS Science and Human Rights Innovator Award for MediCapt, a mobile app that allows clinicians to capture and document forensic medical evidence of sexual violence to support investigations and prosecutions of these crimes. Next slide, please. Physicians for Human Rights is an international NGO established more than 35 years ago. We use science and medicine to document human rights violations to support accountability in the United States and around the world. Our core areas of work include documenting torture and mass atrocities, attacks on healthcare workers, and sexual violence. Next slide, please. Over decades, we've seen that sexual violence cases are among the hardest to prosecute. Most survivors don't report these crimes because of stigma or fear of retaliation, but some do come forward. They want their day in court. Oftentimes, these cases fail because of poor evidence, perpetuating a culture of impunity. Evidence fails because forensic exams are rarely conducted, medical charts are incomplete or illegible. Doctors, nurses, police, lawyers, and judges don't coordinate with each other. And hospitals and police stations often lack locked cabinets to store confidential medical records, risking loss, theft, or tampering. Next slide, please. So 10 years ago, we established the program on sexual violence in conflict zones at PHR to address these challenges. We train medical and legal professionals all together to strengthen the way they collect, document, and preserve forensic evidence of sexual violence to help support prosecutions of these crimes. We also cultivate networks of collaboration among medical legal professionals, so colleagues can work with each other more effectively on a case-by-case basis to increase the likelihood of successful prosecutions and ultimately to better support the survivors at the center of this process. We've been working in Kenya, the Democratic Republic of the Congo, and Central African Republic. Through low-tech trainings, we strengthen survivor-centered, trauma-informed techniques to obtain, for example, informed consent, carry out a full head-to-toe exam, and conduct pediatric evaluations. We reinforce documentation best practices by using standardized forensic intake forms like the post-rape care form or PRC form in Kenya. And we train clinicians to use new skills like forensic photography. Next slide, please. It's within this context that we developed MediCapt, a mobile app that pairs a digital forensic medical intake form with photo capture capacity. Next slide, please. MediCapt allows clinicians to capture more compelling medical evidence during a patient encounter, to preserve it securely in the cloud, and to safely transmit it to the justice sector to inform investigations and prosecutions. The app aims to improve the quality of forensic evidence collected in sexual violence cases, and to do so in a secure and confidential manner, to bypass those basic infrastructure hurdles like stockouts of the paper form, and to strengthen the safety, integrity, and chain of custody of evidence, ultimately to help improve accountability in prosecutions. I'm delighted to introduce my colleagues on this journey who will speak next. Dr. Ranit Mishori is PHR's Senior Medical Advisor, where she provides technical and medical expertise to the MediCapt project. She is a professor of family medicine at the Georgetown University School of Medicine and currently serves as Georgetown University's Chief Public Health Officer. Dr. Mishori will speak about the co-design and development of MediCapt. Suzanne Kadenda is a Senior Program Officer for PHR in Kenya, where she leads the implementation of the MediCapt project, as well as our forensic trainings for service providers. Suzanne will speak about the pilot and implementation of MediCapt in Kenya. And Dr. Sylvester Mesa provides curative, preventive, and counseling services at Naivasha County Referral Hospital in Kenya. He has years of experience in responding to sexual and gender-based violence and serves as an expert witness for these cases. Dr. Mesa was part of the first cohort of clinicians known as the Pioneers, who piloted the app in Naivasha in 2018. He will speak about his experience as a clinician using MediCapt. Over to you, Ranit.
Thank you so much, Karen. It's a delight to be here, and I'm so excited to tell you about this wonderful app. Next slide, please. So when we at PHR were working on the idea of MediCapt, we decided to let the evidence and unknown frameworks guide us in the development. And one of them was the principles of digital development. Next slide. One of the key, go back one. One of the key features of this, of the principles of digital development is the idea of co-designing any digital device with the end users in mind. So recognizing that the development and implementation of such new devices or technology will benefit immensely from the active engagements of those who are supposed to be using it in the field. So the idea is of participatory design or co-design, one that focuses on the needs of the people who use them, in this case, the clinicians who are going to be the data collectors from the patients who are themselves survivors of sexual violence. And working with the clinicians, next slide, please. We work with them in each phase of the development of MediCapt. First of all, initially as a needs assessment. One of the first sessions we did with the end users was, what would be your dream app? What are some of the issues that you must have to make it work for you? What are some of the issues that you should have to make it work for you and for your colleagues in other sectors? And what could you have that is not a top priority, but one day you would like to see it happen? You would like to see it implemented and incorporated into the app. Next one. The initial needs assessment and sort of dream app design, which was more on paper than in reality, was followed by the initial prototype development and subsequently field testing of the prototype. So based on all the feedback we received from the clinicians, we put together phase one, we called it MediCapt 1.0, and then brought it back to our clinicians in the DRC and in Kenya to test drive it, so to speak, and refine the next step, which would be the development of MediCapt 2.0. You can go to the next slide. And then looking at the usability of this prototype and what improvements we could make based on the clinicians testing it out. Next slide. One of the most important things we learned about incorporating this new technology into the workflow of the clinicians was related to the context in which this was going to be working. So as you probably know, this kind of technology, mobile technology, and any technology in the context of a clinical encounter is not so new and not so unusual for people in the global north. But in the global south, this is a little bit more complicated, and especially for some of the patients and some of the survivors coming to the exam room to talk to the clinicians, this could be something that they've never seen before, a doctor using a tablet or a phone or a computer, whereas in the past everything was paper-based. So we did a lot of training about how to use the technology in the exam room as part of a triad of a patient, a doctor, and the technology, and also relied on a lot of evidence and research in the field from multiple parts, multiple countries around the world. So this part is still ongoing, and we continue to refine the app and the work on its usability. And my colleague Suzanne Kidenda, who is based in Nairobi, Kenya, and is leading the implementation and the field work of MediCapt, is going to speak next and explain exactly what is going on at the moment following the initial development. Suzanne, over to you.
Thank you, Renit, and welcome everyone. So I will just give a brief summary of what we've been doing with the application in Kenya. So we initiated the project in 2017, and one of the first things that we did is a roundtable with stakeholders to collect feedback and to be able to strategize for the pilot. We also conducted a feasibility assessment that would then inform our strategy for actually piloting and implementing the application in the country. So once we did this, we settled on a county-based approach to our piloting and our scaling. And the assessment helped us to understand what the challenges would be for the challenges and the opportunities would be for integrating MediCapt technology into the medical and legal systems in Kenya. So we focused on what the current mobile technology is, what the existing electronic medical records systems that were being used at the facilities were for future integration of the application, and of course the current models in use for sexual violence response and patient care at select facilities. All of this helped us to come up with a strategy that would be sustainable and effective as we piloted the application. We've currently piloted MediCapt at 2 health facilities in Kenya. We piloted in the first site in 2018 and the second site in 2021. Dr. Mesa, who has joined us today, will be is part of the team that initially piloted MediCapt in the country. So both pilots involved 3 phases, the training and capacity development phase. And for it to be effective, we had to do a series of progressive trainings over the course of the pilot. And this included foundational trainings on evidence collection and documentation. We had specific MediCapt trainings where we introduced the application and the hardware to the end users. We had specific trainings for technical support teams at the hospitals, because they would be the first line of support in case of any troubleshooting needs at the facility. We then had additional advanced trainings on issues such as informed consent and forensic photography. And eventually, as you can see in the image there, we had sessions where we had simulations with standardized patients, just to ensure that the end users had the confidence and the skills to be able to use this technology with patients. And so one of the other things that we had in terms of training were a series of refresher trainings once the application has gone live. And the topics or modules for the refresher trainings were guided by the end users and the feedback that they gave us on certain areas where they felt that they perhaps needed a bit of additional information, additional support, just to ensure that they were confident and comfortable as they used the application. One of the things that we had to shift with was during the pandemic, we had to use some sort of hybrid training strategy, where some of the sessions that we held were conducted remotely for obvious reasons. So that is something that we also had to take into consideration during the course of this year when we were doing the second pilot. So the focus of the trainings was on a number of things. We assessed familiarity with smart gadgets. We conducted trainings on using the tablets. We had sessions on, as Ranit has mentioned, mobile technology with patients. And of course, we had a lot of discussions around consent, especially while using digital technology. We can move to the next slide, please. The second phase of the pilot was what we call the field testing phase. And this is the period at which the end users practiced use of the application and the hardware. So some of the things that we covered here included protocol reviews and testing, and some of the protocols that we focused on included things such as escalation procedures in case there were any issues that they'd like to share concerning the application, troubleshooting, any other concerns, perhaps with consent or security, anything that might be an issue. We set aside this time for them to practice, to test it out, just to make sure that everything was flowing smoothly. We also used this time for them to adapt to using the technology within their normal workflow, and of course to gain confidence as they used it. One of the important things that the field testing period assisted us with was to be able to get feedback on the usability of the application and the hardware that we were using for this pilot. And so during this period, we got a lot of valuable information that helped us to improve on the application. Can we move to the next slide? And the last phase of the pilot is when we actually went live with patients, so the actual pilot with patients. And during this period, of course, aside from the practice that they were doing, we also developed a technical support infrastructure so that if there were any technical issues that came about, we had a fast line of support at the hospital for the end users, so that they were able to gauge what needs escalation to PHR, what are they able to deal with within the facilities. We were also able to get a lot of feedback on the clinician and patient interaction. Although they had simulated sessions, this was the first time that they were using it with actual patients. So there was a lot of learning to do, especially when it comes to explaining the consent process, especially when you're using these gadgets, so that the patient is aware of what's happening and they are able to give actual informed consent. We had continuous improvement and updates to the application because of suggestions that the end users had. And then of course, at this point, because we had live data coming in, you're able to monitor the backend data. And we were able to use this data to assist the records people at the hospital to be able to collect their monthly summaries. And this is important because we don't want to give them additional work to do, so that they have an extra layer of reporting to do. So by integrating MediCapt into the hospital systems, we're also able to assist them to do some of the administrative tasks that they have to do. And then lastly, we worked with forensic experts to be able to give feedback and to review the documentation that was being filled in through MediCapt, and to give feedback on the quality of this documentation. And Dr. Ranit is one of the experts that we're working with to do this at the pilot phase. And so I will now hand it over to my colleague, Dr. Mesa, to just walk through and discuss what his experiences were piloting the application at the first site in the country. So Dr. Mesa, karibu, and I will hand it over to you at this point.
Hello, good evening. My name is Mesa. I'm going to take you through MediCapt and how the process started. And I remember the first thing MediCapt did was train the users. And the first training they did was on terms of examination. And then in terms of documentation. Then training, we had another training where it was multi-sectoral approach when it comes to use of the documents that are presented in court. And the PRC form came in hand, and we were trained on how to do the presentation in court. Then now we moved to moving from analog to digital when we started using the gadget. We were introduced to MediCapt and then training of clinician on how to use the gadgets. The biggest challenge was the speed at which people are using the gadget when it comes to seeing patients. And then also availability of the gadgets. That was one of the other challenges that we had. And then there was also issue of internet and also storage of the gadgets and the number of clinicians available at the facility to use the gadgets. So after training, more clinicians were recruited into the exercise, and which really made different departments come into play when it comes to use of the gadget. And this really helped in terms of service provision, because initially we will wait for one book to be filled from one department, then it moves to the other. And another challenge we had was storage of the gadgets and also printing of the documents. And the good thing is PHR responded in time, and we had more gadgets being brought in and also designated the area where printing could be done. One of the advantages we had was the challenge we have been experiencing was the aspect of consent. At times you collect information from the guardian or you collect information from the guardian, but you're not able to account for the person who gave the information. So MediCapt really helped when it came to consent, because this is the first document you need to take the patient through for him to allow you to examine and also collect information from the patient. And then we also had the unlimited characters that you could fill into the form, which also played a key role when it comes to collecting information from the patient. And then there was also the aspect whereby at times you will go to court and find that a document you're presenting is partially filled. You'll find that a document you're presenting in court is partially filled. So MediCapt made it impossible for someone to print a document that is partially is not completely filled, and this really helped us when it came to collecting all the necessary evidence and information that is required in court. And then there are also other aspects of leaving blank spaces during examination of a patient. This was well catered by MediCapt, because you couldn't save a document or print a document with blank spaces. So all essential information was fed into the system. And then there was also, after filling the collecting history, examining your patient, the first person who had seen the patient was required to make a diagnosis or an impression correlating from the history, physical examination, laboratory findings. So it created a space whereby someone will give an impression of his finding or her findings, which really helped in terms of giving an impression or a diagnosis after examination. Then also the key thing now, which also I believe was the game changer in MediCapt, was the aspect of forensic photography. I'll give an example where I went to court and this patient came in. He had multiple cut wounds which were stitched. And then at the time the case was starting, the wounds had healed. The clothes the patient was putting on that were blood-stained could not be availed in court. But with MediCapt coming in with the forensic photography, it really helped in terms of taking photos of the injuries and also taking photos of the clothes the patient was putting on so that you can be able to show them in court in terms of evidence. And I believe with the quick response when it comes to changing the documents and improving where there are gaps, it has really helped in terms of service provision and also capturing the essential information required in order to deliver justice. I wish to stop there unless there's any question. Over to you, Nate.
Thank you, Mesa. Thank you for that. Please, can you go to the next slide? Thank you. And just before I begin, I'd like to just remind everyone that in case you have any questions, please post them through the Q&A option. It should be available. So after we conducted the second pilot in the country, we were able to do a MediCapt evaluation to give us some feedback on how the application has performed and how the pilot has gone. So the evaluation was done across the 2 pilot sites. Both of these sites were in the same county, and it involved key informant interviews, focus group discussions, questionnaires, and medical record reviews related to MediCapt implementation. So the purpose of the evaluation was to be able to gauge the effectiveness of MediCapt as a tool to document forensic medical evidence of sexual violence, as well as whether it improves the forensic evidence collection process and whether the document quality improved compared to paper-based forms that clinicians usually use. And so we conducted 57 semi-structured interviews, 336 records were reviewed, and we were able to administer a usability questionnaire to 14 participants. So in terms of results, the evaluators, external evaluators that we used found that MediCapt forms had a significantly higher data quality score compared to paper-based forms. In fact, the higher scores were at about 88.5%, which translates to 23 out of 26 questions in the data quality checklist that we used. This quality checklist is a novel tool that was developed by PHR to help us identify and score specific elements of the Kenyan post-rape care form to be able to assess for completeness, for accuracy, for timeliness, as well as legibility. And we found that MediCapt had significantly higher scores in this, as well as MediCapt appeared to not only improve the quality of documentation, but it seemed to standardize the quality across the 2 sites. And so those are just some preliminary results from the evaluation. We'll be able to share a finalized report from this evaluation once we have completed it. One of the things, or one of the feedbacks that we got from the Ministry of Health in the country is through their data collection system, the DHIS system that collects data on sexual violence. They were able to see that there was a marked improvement in the documentation of the first site, the first facility where we piloted MediCapt. And this occurred during the period where we had started the pilot. We had conducted the various capacity development activities. And so they could tell from the quality of data coming out that there had been some sort of shift. And you may have seen when Mesa was talking about the feedback from the end users, that this also was accompanied by an improvement in the quality of treatment and care for the survivors because of the extra detail and attention that went into documentation and into treatment and eventually into care. Throughout this whole process, we've also been able to engage our other multi-sectoral partners. So we've worked with the law enforcement officials as well as judges, magistrates, and prosecutors, and we've engaged them in various discussions around the application. And even through the evaluation, we found that MediCapt was acceptable within the courts. It had already been marked as an improvement in terms of legibility, in terms of comprehension, and just as the amount of detail that the MediCapt forms were giving when it comes to the court process. And so we will continue to work with them because the second phase of the MediCapt pilot will include integration with the police systems as well as the court systems to better secure the transmission of these documents and this evidence to the different sectors. Because currently the forms still have to be printed out. We're hoping that once this integration is finalized, then the police officers will be able to access these forms and to view these forms via the application itself. And the same can be shared with the court systems, and they can use this as they prosecute the cases. So I will stop there so that I can give time for any questions, and I will hand it over to Mindy. Thank you.
Okay, folks. We are hoping to have a discussion here. Okay, we sometimes experience a bit of technical difficulties on these events, but thank you for bearing with us. We're connecting several continents. We want to encourage your questions, so please put them in the Q&A function, and we'll try to get to them. But for now, I'd like to hear more about how you enabled word of this innovation to reach across a country as large and diverse as Kenya. Were your materials in different languages? Did you work with local medical associations? Have you reached out to medical schools? How has this been received in the community? I know you've talked about that some, but let's talk about it a bit more.
Thank you, Mindy. As I had mentioned, we initially started with a more national approach where we were working with the Ministry of Health. But from the feedback that we received, and because health is a devolved function in the country, the best approach towards piloting and eventual scaling was via the county departments of health. And so that's the route that we took. And as PHR, we got into formal agreements with the county that we're piloting in to support us as we piloted and to support eventual scaling to other facilities in the hospital. So that's one way that we've done it. Outside of that, and as part of our other programs and our other projects that we're running, we also have partnerships with, as you said, with medical training institutions, with other health facilities, with the Ministry of Health, with other departments such as gender. And through our other work, we've been able to sensitize them on MediCapt. We've been able to introduce MediCapt to them and to share with them our plans for further scaling of the application. And through this, of course, and through references and word of mouth, we've had a lot of partners reach out to us also just to hear about the application and to get additional information. I should mention that during the pandemic, where a lot of things have moved digital and there's been a lot of interest in working on digital systems, we've had a lot of interest to pilot in other areas of the country. And so we wanted to do this pilot to get the results from this evaluation, just so that we can use this to see whether there are other areas where we need to improve on, whether there are additional things that we need to work on both the tech side as well as the the support side, so that by the time we have additional people using the application, it's ready. And one of the things that I should mention is that MediCapt is geared to be an open source application. So it will be available to everyone who wants to download it and to use it. And part of the things that we've also been working on is a toolkit that will go hand in hand with the application itself, so that everyone who wants to use the application will have the necessary documentation and information to be able to do so. This will include the different training curricula that we've developed to guide the training sessions that I've mentioned. It will include clinical guidelines for the use of the application. It will include the various protocols that we have for technical support. So it's an entire package that we're working on and that we've been piloting throughout these years. So yes, I hope that answers your question.
Okay, we are starting to get some questions. Please continue to send them in. We have a very interesting one from Mel 10. I don't know where Mel 10 is from, but he's asking if the app can be used on any operating system, Android or others. And is there any difficulty in documenting injuries using the phone or the tablet?
I'm happy to take the documentation part, and maybe Karen can talk about the operating system. Clinicians generally know how to document it, but of course, when you switch from a paper format to a digital format, it requires a little bit of practice and training. Part of our training, part of our package is that we offer the training in forensic photography. Again, there's a difference between taking a picture of any injury versus something that could be admissible in court and that should follow certain parameters that make it more likely that it could be used as a piece of evidence in a legal process and procedure. So it requires a little bit of training from how to position the patient, to lighting, to distancing, to using rulers. And so I think that's, as Suzanne mentioned, this is going to be part of the toolkit that comes with MediCapt. But generally speaking, if you know how to take a picture on a smartphone or on a tablet, that's all it takes, with a little bit of extra skills that relate specifically to forensic photographs. And I'll pass it on to Karen.
Thank you. Yeah, so I'll echo my colleagues Ronit and Suzanne, who've already answered so much of how we've been engaging in this effort and the partnerships and the thinking behind it. To answer the question, right now, MediCapt is available for Android operating systems, and down the road, we hope that this will be something that's more widely available with Apple. But actually, we did quite a lot of analysis when we were first starting out back in, we've been working on this now for several years, and we determined that Android was actually more widely available in lower and middle income countries, which is where we were initially piloting the app. And of course, the app is designed, as Suzanne mentioned, to be open source, so to be available for clinicians to do documentation in other contexts. And so we hope very much that over time, the tool will be adapted to different jurisdictions, different countries for availability for documentation. The piece that I also just wanted to mention, Suzanne has done just masterful work engaging with partners in Kenya, in government, in non-government organizations, and of course on the medical side and law enforcement and legal stakeholders. That has been absolutely critical in ensuring the credibility of the tool. The other piece that I wanted to mention, though, is that we have the tool really is within this broader context of PHR's low-tech training, the training on bringing together, as I mentioned earlier, clinicians, police officers, lawyers, and judges on the most effective ways of gathering evidence, forensic evidence of sexual violence that it just require, as Suzanne mentioned, obtaining informed consent, doing a full head-to-toe exam, really understanding the context of sexual violence, thinking deeply about attitudes, behaviors, practices that can inform documentation. So it's building on those skills that we then introduce MediCapt to clinicians who have already gone through this cross-sectoral or multi-sectoral training, so that this is one more tool in their toolbox that really supports the documentation process. So that's it's an important piece, because it's not just technology for technology's sake. It's a one more tool in the toolbox as part of this broader landscape of engagement with these service providers.
Okay, thank you very much.
Mindy, can I add something to the question
Please.
about the photography? One
Please.
thing that we didn't mention is the safety, security, and confidentiality of the evidence that is being documented and collected through MediCapt. And of course, you can imagine that this it being used for sexual violence documentation, there's a lot of very, very intimate and sensitive information and photography that is being collected. One of the innovations of MediCapt is that when you take pictures, you take a picture through the app, and it doesn't leave the pictures kind of hanging in your photo app on your phone or in the tablet. So it removes these photos, so it's not like you're going to have pictures of injuries or survivors who may not want their pictures shared with other people on your phone or on your tablet. You take the picture through the app, and it immediately kind of uploads it into the cloud, and so there are no traces of it left on the device, which is one of the key features of maintaining the confidentiality and the safety and security of the individuals whose information we're collecting. And then the other thing I wanted to mention to build on what Karen was saying is, yes, it is built, the app is a part of a toolbox that is built on low-tech training, and that's really, really important. And Suzanne mentioned the quality seems to be enhanced for users of MediCapt, and that is because the app itself has prompts for clinicians who may be so busy. If they were doing this in a paper-based system, they might just go from step 1 to 2 to 3 and skip step 5. This app does not allow you to skip certain really, really important pieces of information that could be used for the legal process of accountability and justice for these. So part of the issue is the app that's providing reminders for clinicians about what's important to collect for the purpose of a legal process of sexual violence documentation.
Okay, well, this is really very helpful. We've had a question from Samrawit Asefa Melis about the training, and I think you've spoken quite comprehensively to that. We can go back to that in a minute, but I do want to pose the question by Oliver Molds, Dr. Oliver Molds, who's been really a force to enable us to present these webinars through the Science and Human Rights Coalition. And he has really shepherded this for a number of years. And he is asking, again, you've touched on this, but perhaps you can say more. How widely is MediCapt used in Kenya? And I know some work is being done as we speak in the Congo. And what difficulties have people been encountering in gaining use?
I can take that question. So currently we are piloting MediCapt in 2 facilities in Kenya. So as a pilot, we settled on 1 county in the country, which is Nakuru County. And we started initially with 1 facility in Naivasha, which is where Sylvester Mesa is from. This was the first site. And earlier this year, we settled on a 2nd site, guided by the county's recommendations based off of the number of survivors that they were seeing. So as I said, we work in collaboration with them. And so we, all these decisions were made in collaboration with the county. In terms of some of the challenges that we've had with the usage, I think one of the biggest things is the requests for integration, but the process of integration is very difficult at this stage. So one of the things that we keep getting from the facilities is the ability to be able to integrate the application with the current health management information systems that they're using. But it's a tall order at the moment because every facility is currently using different electronic medical record systems. And so to be able to get the necessary information to integrate to these systems is quite difficult at this point because of various things. But of course, there's the issue of security and being able to vouch for the security of these systems, because the data that MediCapt is collecting is very, very sensitive. And so that's one of the areas where we're getting we're a bit slower than we would like to be, but eventually we hope that we will be able to do this integration because it makes sense. It makes sense to integrate to the systems. It makes it easier for the clinicians and the nurses using the application, and it makes it easier for the people who are collecting the data on the back end. So that's one of the areas where we are a bit behind and are trying to just work with the various stakeholders to make this possible. And then, of course, as I mentioned, we're currently working on the second phase of the application, which will allow the law enforcement officers and the court officials to be able to access this information. So the way it will work is that the clinicians will still be the ones filling out the medical legal forms. The police officers will be able to view with their unique credentials and passwords, etc. They'll be able to view the forms that have been filled out at the hospitals and to be able to pass them on to the necessary prosecutor, magistrate, whoever at the court needs to see the forms. So this is also, we're working on this as well, and we're hoping that by next year we'll be able to have made some way forward on that. So those are some of the areas where we're still in progress, and we're hoping that we'll be able to make some headway very soon.
And I'll just jump in here to mention that we have also been working in DRC, and we've recently piloted the app at a hospital, a major center of excellence in North Kivu, Heal Africa. So we're really excited to see how that process goes in a very different context, very different landscape. We've been working with clinicians in DRC to help co-design the features of MediCapt for years, and it's very exciting to finally be at a stage where we're able to work with clinicians to pilot the app with patients. As Suzanne mentioned, every hospital, every facility has its own workflows and patient pathways. Some have electronic medical records set up, a system set up, others do not. And our goal with MediCapt is to really have the tool be adaptable to any circumstance. So it's really exciting to test out the tool in Kenya and to test out, exactly as Suzanne mentioned, the interoperability of the tool in locations in Nakuru, whereas in DRC at Heal Africa, they don't have the health electronic medical records, in which case then MediCapt is serving as that function. So it's really a diverse landscape with every context has its own specific unique needs, while there is also universal application. And that has been a very challenging but very exciting component of designing, developing, and implementing the tool in different sites.
Okay, that's really helpful. I want to turn to a really interesting question from Teresa Harris, who's been a vital force in the Science and Human Rights Coalition and the program, and has been directing it in a very lively and stimulating way for several years now. And Teresa, who herself is a lawyer, is asking, have you seen changes in the outcomes of legal cases as a result of MediCapt? Have there been changes in the way survivors of sexual violence pursue their rights as a result of the improvement in the documentation? So there's a lot there, and I'm sure some of the attorneys in the audience would be very interested in what you can respond.
So, Suzanne, why don't you speak to the situation in Kenya, and then I can speak a little bit about DRC.
Okay, sure. So in terms of the changes in outcomes in legal cases, one of the things we were hoping to find during the evaluation was perhaps how MediCapt has been used through the pathway of service provision and in court. But although the forms have made it to court, we haven't gotten to the stage where we have judgments from some of these cases that where MediCapt was used. But what we do have is feedback from some of the police officers and some of the judiciary officials that we have interacted with throughout this process and who were interviewed during the evaluation of the pilot and the application. And of course, some of the things that we had is that, of course, the MediCapt forms are more comprehensive. They have more information because of the feature where you cannot submit a form that isn't complete. There are certain required fields in the application, and this was through feedback that we got from the lawyers themselves, from the prosecutors, from the judges, on what are some of the key things that they look for when they're reviewing some of these medical legal documents in court. So these fields were made necessary, and so you cannot submit a form that doesn't have these fields filled out. So this means that the information in the form is comprehensive. One of the challenges that we've had with the paper form is that the space to make any observations and to write out your history, etc., is very, very limited. It's just one sheet of paper that requires you to fill out all this information. And so, as Mesa said, the MediCapt application gives you unlimited space to fill in this information. And on the flip side of this, one of the things that we had that wasn't a positive with MediCapt is that because of this, people tend to give the information, and so you'll end up with a very long form in court. So this is one of the things that we also have to work with. But yes, you end up having all the necessary information, and you end up having, one of the things we included is a field where the clinician can give their assessment, can give their findings and some sort of conclusion, which, you know, a lot of people didn't do before because there wasn't the necessary space. And so now it's very easy in court for the expert witness or the clinician in this case, or the nurse in this case, to actually focus on that assessment and explain what their findings were and give their expert statement and testimony in court. So this is one of the advantages that we've had from our justice sectors. And then, of course, we have the inclusion of body maps, as well as the photographs that enable you to not only have the injury shown, but you can also describe the injuries at length. So you're able to give your findings based on the history that you had and received. Do any injuries match with that? And you're able to give your findings. In the absence of injuries, we also have the psychological assessment bit that helps you to also note down and gives you cues on some of the symptoms that you can document to help with the case. So you won't be able to have any conclusive findings in terms of things like PTSD, etc., but you'd have some sort of way to follow up with the survivor to be able to complete that process and have the necessary documentation. So there are a lot of advantages that we've had for the court process, and we'll be sure to update all our stakeholders once we have these judgments that have come out from the use of MediCapt forms.
And I'll just, thank you, Suzanne. And I'll just jump in here, Teresa. You know, we're of course not as far along in DRC as we are in Kenya. So, and in Kenya, as you've just heard, we haven't gotten to the point of judgment. Sorry, Mesa, did you want to jump in?
Jump in concerning the question that had been raised. We had this case in court whereby it was a case of harassment, filling the part A of physical examination and history taking. And the judge was like, how was the child? And initially we had a problem whereby people didn't choose to fill the part B of the PRC form. So
Mesa?
I think we
Really?
lost him.
I think we lost him. I'll just jump in here. I hope he comes back because, oh, here he is. Go ahead, Nessa.
You're
you're on
muted,
mute.
Nessa.
I was saying, when we're looking at the part here now, when I read through what was filled, it showed that child was traumatized and in need of psychosocial support, which really helped in terms of making a diagnosis for now the patient was the form was completely filled, and the psychological part showed as much as there was harassment, this child was traumatized after the incidents. So really MediCapt has come in hand when it comes to filling that form completely.
Okay.
Maybe I'll just jump in just to mention though, and I appreciate Messa's experience so much, and I think just the importance of as all the panelists have mentioned, the importance of clinicians actually documenting each of the fields has been, and the app forcing that discipline has been very, very valuable. The piece I just wanted to mention with respect to DRC is that while we haven't gotten to the point yet where we're able to establish the impact that MediCapt has been having on judgments, we have gotten to the point where we're able to see very clear indicators of medical evidence helping to support convictions in DRC and the impact that that's having in the justice process and survivors coming forward. And here I'll just offer that we had this landmark conviction in 2017 in DRC called the Kavumu case, and I'll post a link in the chat, where a sitting member of parliament, a very powerful man in the Kavumu community, who was also a chief of a militia in that community, was convicted of crimes against humanity along with 10 members of his militia for brutally assaulting more than 42 young girls in that community over the course of 3 years. And through really comprehensive medical documentation of clinicians that PHR had worked very closely with and trained for years on forensic documentation, and the established network of clinicians and police officers and lawyers who had been trained to work with each other and to work together on the investigations and ensure that the medical evidence could inform investigations and prosecutions, we were able to have this really landmark historic conviction where the judges actually cited the comprehensive nature of the medical evidence that helped to inform their adjudication of these cases. And that case has been studied and adapted and has informed many other cases in DRC and beyond. So we are seeing traction of this medical legal approach, and we absolutely hope that MediCapt, through the discipline that it offers, will be able to further reinforce that comprehensive medical evidence to inform the investigations and prosecutions that we're seeing and ultimately yield greater likelihood of success in court.
Well, thank you very much. We're close to the end of our time together, and I am sure there are more questions here lurking, and we're going to be posting the email contacts for people, and I hope you will use them to learn and to share and perhaps to think about initiating some trials in your own communities of MediCapt. Is there any last word any of you would like to share with our audience? We don't know where they're from, but I suspect they're from across the world. Messa, it's wonderful to hear from a clinician. Any other words you want to say in terms of engaging clinicians in this? What seems to really be attractive to them and should be stressed in any future field trials? Well, maybe we can't reach Messa.
Maybe, oh, sorry, go ahead, Suzanne.
I think there's a lot more to MediCapt that we weren't able to cover in this hour. So I would encourage anyone who has any additional questions, any clarification they would like to contact us on the emails on the screen. We're happy to field any questions, and we're happy to have any additional meetings or convenings to follow up.
And I'll just jump in here to just really say just enormous gratitude to our partners like Dr. Mesa and many other colleagues in Kenya and in DRC who've been on this journey with us and have really trusted this process and are engaging in this pilot with us. We're very grateful for their generosity, their time, and their partnership. And thank you to all of you for giving us an opportunity to share news about MediCapt and our work. And we hope very much that we'll be able to continue to work with you on this project and share updates in the coming years.
I really am overjoyed that we could do this, and I want to send a real shout out to the technical staff at AAAS. It's not easy connecting Israel, different sites in Kenya, different sites in the United States, and have it pretty much worked out well. And again, we hope you'll reach out to the staff at Physicians for Human Rights. They are welcoming your concerns and your questions and your engagement. And thanks again to Jamie Stevens, Kathy Arias, Nathaniel Weisenberg, particularly for all that he's been doing, Teresa Harris, Ali Moles, and we welcome your connections with us in the future. Thank you again.